Hello again, and this is chapter 26 for Nursing 1, and we're going to talk about heart failure. So follow along with your PowerPoint. What are we going to talk about? We're going to talk about the pathophysiology that differentiates left-sided and right-sided heart failure. We're going to define what acute heart failure is versus chronic. We are going to talk about the different types of symptoms that are associated with both left-sided and right-sided heart failure, signs and symptoms. We're going to talk about the nursing care that you have to provide for patients with heart failure. We're going to talk about medical treatments, differentiate between acute and chronic. We will also talk about teaching and patient education for patients that have heart failure. So you might ask, what is heart failure? Well, that's a really good question. So heart failure, the way the book defines it, syndrome that occurs from progressive immobility or inability of the heart to pump enough blood to meet the body's oxygen and nutrient needs. Let me try to make that a little easier for you. In your body, your blood goes one way, and everything in your body is a one-way street, just like South Philly. Whenever anything goes backwards, that's trouble with a capital T. So with heart failure, you have one of two things, or it could even be both, but that are happening. Number one, with left-sided heart failure, you have to picture the anatomy of the heart. When we look at the left ventricle, the queen mother of the four chambers, that left ventricle is supposed to expand and fill up with oxygenated blood and then contract and pump that blood filled with oxygen out the aortic valve through the aorta to your brain, to your tissues, to your organs, to your whole body, right? With left-sided heart failure, there's a problem with the ability of that left ventricle to expand and contract fully, push that blood out. So what you get is a backflow of blood. So the blood will flow backwards from whence it came, from the left ventricle up through the mitral valve, back to the left atrium, and then where did it come from to get to the left atrium? The lungs. It's going to back up into the lungs. So with left-sided failure, clinical manifestations are the lungs. Pulmonary edema. You're going to hear crackles when you listen to the patient's lungs because of that backflow of blood and a fluid accumulation in their lungs. Left-sided heart failure, left is lungs. With right-sided heart failure, now you're talking about the right ventricle. And the right ventricle's job is to expand, fill up with deoxygenated blood, and then pump, boom, and pump that deoxygenated blood to the lungs to get rid of carbon dioxide, pick up oxygen, and go to the left side of the heart. So when the right ventricle fails, blood is going to flow backwards from the right ventricle through the tricuspid valve to the right atrium. And where did it come from to get to the right atrium? The vena cava. Inferior and superior vena cava, the biggest vein in the body. And so it's going to back up into the vena cava and back into the body. So patients with right-sided heart failure are going to have symptoms of the body, in other words, peripheral edema, feet, ankles, lower extremities, swollen, filled with fluid, abdominal ascites, an accumulation of fluid in the peritoneal cavity, or jugular vein distension. Now, I can sometimes make my jugular veins a little bit, but you could see it a little bit. JVD, jugular vein distension, is a sign of one sign of fluid retention and one sign of right-sided heart failure, because when that blood backs up to the body, that's one of the bigger veins that you can see, and it will sometimes bulge. So jugular vein distension is also a sign of right-sided heart failure. Okay, so just remember, don't remember anything else right now. Clinical manifestation. We're talking about heart failure, left versus right. Left is lungs, right is body. Left is lungs and right is body. Okay, with me so far? Cool. Well, what causes it? What's the etiology? One of the most common reasons is coronary artery disease, CAD. So in other words, the coronary arteries, those little teeny arteries that feed the muscle of the heart, the myocardium, are not getting sufficient blood flow to the myocardium. And so when the myocardium doesn't get enough oxygenated blood, it gets weakened and it can't squeeze appropriately. And if the myocardium can't squeeze, then the ventricles can't pump. So that's the most common reason for heart failure. But there are other reasons like cardiomyopathy, which I'm not going to really get into right now, hypertension, which is all too common, some valvular disorders, the mitral valve prolapse is a big one, aortic valve regurgitation is another big one, or actually having the patient having had an MI, a myocardial infarction, or heart attack, as laymen call it. And so, the book goes on and talks about, if the pumping ability of either of those ventricles is impinged or inhibited, then what's going to happen is patient suffers from heart failure. Usually, the left ventricle is the first one to go. Not always, but usually. And then usually, when the left ventricle starts to fail, the right is going to follow, which, stinks. Okay. So I threw a little diagram for left-sided heart failure in that PowerPoint so you can look at it. And then, right-sided heart failure, we talk about the blood backing back up, right? Something called cor pulmonale. You don't necessarily need to know what that is, but just understand cor, talking about the heart, pulmonale, talking about the lungs. So the heart is backing up blood to the lungs, right? And that's left-sided heart failure. Then there's a diagram for right-sided heart failure. Here's the thing about the body with heart failure. Number one, it is a progressive and degenerative type of disease process. So in other words, once a patient develops heart failure, it's not getting better. Now, we can sometimes slow it down from getting worse, but it getting worse is almost inevitable over time. Okay, so understand when we say something is progressive and degenerative, that means that it's going to get worse over time, and that's important to know. The compensatory mechanisms are pretty much amazing. So you'll see people with heart failure will be tachycardic. Why? Well, because the heart's going, I don't know, we're not getting enough blood flow to the body. Let's beat faster. Maybe that will help. It won't, but body's trying, right? We'll see the kidneys, which have a system in them called the renin, angiotensin 1, angiotensin 2, aldosterone, antidiuretic hormone system in the kidneys, will start to increase fluid volume because the kidneys are looking at the body going, there's not enough blood volume here. What's going on? Let's hang on to a little fluid, which raises blood pressure. So it's this whole chain of events that happens all due to whatever that initial insult was to the heart. And like I said, usually CAD is the most common thing. Okay. And then over time, because the heart's working like really hard, you want muscles in your body, but you don't want your heart muscle to become enlarged. So when we talk about cardiomyopathy or cardiomegaly, which is an enlarged heart, or hypertrophy, the word hypertrophy means overgrowth of, those are all bad in relationship to the myocardium, the heart muscle. Because when the heart muscle gets big, it doesn't work better and stronger. It works less effectively, and that's a problem. So people can, of course, live with chronic heart failure. They will have symptoms like, shortness of breath and fatigue and so on and so forth. But sometimes they will have an acute exacerbation, which is usually full-blown pulmonary edema. So they'll get, in other words, so much fluid backing up into their lungs that they're literally drowning. They're drowning. They can't breathe. They can't lie flat. They can only sit up to breathe. And it's a struggle, right? This is a life-threatening occurrence and usually requires hospitalization. And fun fact, heart failure is one of the 3 Medicare no-pay events because what happens is patients that have chronic heart failure will maybe not watch their diet because they must be on sodium restriction. 1,500 milligrams sodium a day maximum. 1,500 milliliters of fluid a day maximum. So they'll cheat. They'll go to the buffet or they'll go eat Chinese food or McDonald's or whatever, tons of salt. And then all of a sudden they get this huge accumulation of fluid and they're drowning and they wind up at the hospital. And so we will bring them in. We will give them diuretics, typically IV, like loop diuretics like furosemide or bumetanide. get them stabilized, send them home, and then, oh, about a month goes by and they're back. And so that's, a big problem. So Medicare said, well, you better do something about it, like give them home care or follow them after they're discharged to make sure they don't come back. Because if they come back to the hospital within 30 days of the last admission, we're not going to pay you a dime. And hospitals don't like to hear that they're not getting their money. Okay. So with acute heart failure, and it's usually the left, right? So we're talking about lungs, pulmonary symptoms. The patient's going to have typically severe dyspnea, they're going to have cough, and they're going to have pink, frothy sputum. Why? Because the backflow of blood to the lungs mixing in with that fluid that's being retained in the lungs gives them that frothy, pink-looking sputum. The respiratory rate is going to be up. I mean, I've seen patients with a respiratory rate of 42. And just to kind of give you a visual of what that looks like, think about a normal respiratory rate for an adult, 12 to 20 breaths per minute. So when you double that to 40 or 42, here's what it looks like. Not good, not comfortable, right? You're gonna hear crackles in the lungs because crackles is a sign of fluid, okay? And when you can't breathe, guess what else happens? You get a little anxious. So you're going to see increased anxiety, restlessness, irritability. All these things are symptoms of acute heart failure when they're having that acute onset of pulmonary edema. So what do? Well, the thing that we need to do is we need to get rid of the fluid and we need to reduce the workload of the heart, right? So especially that left ventricle. And of course, if we know what the cause is and we can treat it, then that makes the most sense to treat whatever the underlying cause is. So you want to keep your patient in a Fowler's, semi-Fowler's, or high Fowler's position because that's going to make it easier for them to breathe. We're going to give them oxygen, supplemental oxygen. Diuretics, usually the big guns, which are the loop diuretics, like furosemide or bumetanide, that's Lasix or Bumex. Cardiac glycosides, like digoxin. If they're really short of breath, morphine. That's right, morphine, because morphine causes respiratory depression, doesn't it? And if I have a respiratory rate of 42, you want to slow it down, don't you? Morphine. It's used for air hunger, not just pain, right? And then vasodilators, sometimes like nitro. And then there are algorithms or formulas for patients depending on what stage of heart failure they're in that include the diuretic and the dig and maybe an ACE inhibitor, right? So depending on what's going on with that patient. The next slide gives you some nursing diagnoses. And the next slide, 16, gives you really all of the signs and symptoms of chronic heart failure. So they're fatigued and they're weak because they can't breathe. They'll have exertional dyspnea. So in other words, anything that requires movement is going to make them short of breath. You need to know what that means, exertional dyspnea. They're going to present with orthopnea. And orthopnea is the inability to breathe when they're lying supine. They're always upright. You will find these patients, they sleep in their recliners, or they'll sleep in bed maybe, but with 3 or 4 pillows to prop them in an upright position. Because if you're upright and you have fluid in your lungs, gravity makes the fluid go down to the bases of the lungs. If you're lying in a supine position, now the entire backs of both of your lungs is lined with fluid. You can't breathe. They are going to have a cough, probably. They're going to have crackles, tachycardia, sometimes chest pain goes along with it. You're going to see edema, whether it's the pulmonary edema in the lungs or peripheral edema, which is in the ankles and feet, lower extremities, abdominal ascites, jugular vein distension. You're going to see nocturia, which is urinating at night. You're going to see cyanosis because they're so short of breath. Usually you'll see perioral cyanosis. Peri means around, oral is the mouth. So blue tinge around the lips. That's one of the first telltale signs. You will see an altered mental status. Why? If you're not getting enough oxygen and your brain's deprived of oxygen, then your brain can't function properly. And so they'll present confused, disoriented, right? Anxiety. And then malnutrition. Why? If you can't breathe, You don't feel like eating, do you? Because it's really hard when you swallow, you're not breathing. Well, they can't go for even a second without breathing. So they typically are very, very underweight, malnourished. Okay, these are all pretty typical. Diagnostic tests you must know. The first one, B type natriuretic peptide, BNP. That is a lab test that will tell us with a blood draw whether or not the patient's retaining fluid. And a normal BNP is 100 or less. And to put that in perspective, people with significant chronic heart failure, I mean really bad, will have a BNP that for them is their normal between 3, 4, 5,000. Okay, so you need to know that. And then the other thing you need to know is when we do an echocardiogram, which is an ultrasound of the heart, gives us a lot of information. It can see inside the chambers and it can see the valves and see if there's anything else happening. But it gives us an ejection fraction, which is a measurement of left ventricular kind of output. So how efficient is that left ventricle? The ejection fraction should be between 50 and 70%. Anything under 50%, you got trouble. And just to put that in perspective, to be eligible for hospice, if you have an EF of 20% or less, welcome to hospice. Okay? Because at that point, you can't talk without being short of breath. Okay? And, you know, we can do EKGs also to see if there's been an MI maybe we didn't know about, and stress testing sometimes. But really, the two that you need to know for heart failure are the BNP, that blood work, should be under 100, and then the echocardiogram, which gives us that ejection fraction of the left ventricle, 50 to 70%. So make sure you know that, okay? When we talk about drug therapy, again, you know, DIG, we talked about that already. ARBs or ACEs, definitely diuretics to get the fluid out. And then here's one of the most important things, actually two of the most important things. Number one is diet and fluid. They must stay away from salt. Salt is the devil. And so sodium restriction, 1,500 milligrams daily. No more. Fluid restriction, 1,500 milliliters daily. So they're both the same number. It's easy for you to remember. And then the only accurate way to determine fluid retention that as a nurse you can do, patient needs to get weighed every day, not every other day, not once a week, every day, same scale, same location, when they wake up, after they pee, before they eat. Because if they gain 2 to 3 pounds in a day or 3 to 5 pounds in a week, they're getting ready to go into an acute exacerbation of heart failure. That's fluid. That's not, well, I ate too much last night at the buffet. That's fluid. So remember that. Daily weights, daily. Did I say daily? Daily weights, okay? Make sure you don't forget that. And don't forget about the sodium restriction and the fluid restriction. And then I've got some nursing diagnoses there that you can take a look at, a couple quick review questions, and ta-da, heart failure, okay? All right, that's all for today. Until the next time we meet, ciao.